Thank you everyone for joining us on another Surgery Live. Very excited about today's presentation. We're very fortunate to have Dr. Maria Widmar presenting to us in a case from Memorial Sloan Kettering. And thanks to Medtronic as usual for helping us sponsor and make this happen. With that, I want to introduce Dr. Maria Widmar from Memorial Sloan Kettering Cancer Center. She's a good friend. We met on the interview trail and fellows. She was one of the many Marias in our class, and we've become close friends and stayed in touch. And I'm very appreciative that she's present today on rectal cancer. Why can't it be easy? And with that, Dr. Widmar, I'll hand it over to you.
Thanks so much for the kind introduction. I am one of the three Marias of the colorectal class of 2017 to 2018. I'm going to be presenting a case that came before us a couple years ago that I think represents a lot of what we see coming in from the community, and I think presents some interesting challenges. This was a 51-year-old female who presented to us from an outside hospital after undergoing ESD and a piecemeal polypectomy of a lesion at 7 centimeters from the anal verge located anteriorly. The path from that came back as invasive adenocarcinoma, moderately to poorly differentiated with focal lymphovascular invasion, so a high-risk feature. And there was tumor seen focally abutting the deep cauterized margin. This was flexible sigmoidoscopy performed in the office 10 days after the ESD, which showed just sort of an ulcerated scar lesion, but no obvious adenomatous tissue or tumor. So the path from that showing sort of tumor cells just touching the cauterized margin, certainly including mucosa, submucosa. And after she came to us, we proceeded to get an MR of the rectum. So this was about 2 weeks after ESD. She did not have any preoperative imaging. And this is what it showed on higher power, a lot of inflammation. Certainly appeared like some of this inflammation and or tumor extended beyond the wall, the muscular wall of the rectum. And this was staged by our radiologist as a T3B and 0 rectal cancer at 7 centimeters located anteriorly. Just a little bit of background for everybody involved, since I know there are a lot of residents. You know, when we see an MRI like this, what do we think? How much do we trust its clinical staging? From the era where we did a lot of endorectal ultrasound, we know that the accuracy for T-stage with ERAS is about 74 to 91%, end stage a little bit lower. There were some studies, Garcia Aguilar, I think, actually published one of them looking at what's the accuracy of endorectal ultrasound after polypectomy, about 54%, so flip of a coin. For MRI, we know that this T-stage accuracy is actually lower. End stage is probably comparable, maybe a little bit better. It's pretty good at telling us about a CRM, the circumferential resection margin. But we have essentially no data about the accuracy of MRI after someone's undergone polypectomy or ESD. And what we know about MRI, and we've known this through several studies now and quite for some time, is that there is a tendency to overstage tumors, particularly as T3, because of the desmoplastic reaction that we can see. So we're looking at this MRI now after a person's undergone ESD, and the question is, what do we make of it? And I think it's fair to say that when we're looking at this person, we really don't have a true sense of what this person's clinical stage is. At a minimum, this is a T1 cancer with high-risk features because of the local lymphovascular invasion and the poor differentiation. It could be a T2 or could really be a T3, but we are pretty confident about the circumferential resection margin based off of the MRI. So the question is, what do we do and what do we offer this patient? Here are a couple of options. I think probably the most common options, though there are others, and in our DMT when this case was presented, there were other options put on the table. But I think we have a couple of ones that most colorectal surgeons would consider: transanal excision, straight to TME, chemoradiation, or in some cases just radiation, total neoadjuvant therapy, or observation. So I wanted to pose it to the group. What do we think? What can we offer this patient?
Tough case, Dr. Widmar. Thanks so much for that introduction. Dr. Trunzal, my good friend and partner who's logged in with us here, let me go to you. So, in some ways this is harder because the lymph nodes look fine on MRI. If the lymph nodes were positive, then you'd say, all right, well, at least that's a stage 3. So like Dr. Widmar said, can you trust that T3? Is there, the endorectal ultrasound could be an option, but like she said, that's only 50% accurate after polypectomy. What's your next move here?
I think it's really challenging to get a good understanding after that, that cauterized injury to the surface about how how accurate that's going to be. I think you got to sort of start taking into consideration sort of the surrounding factors. How old is the patient? How low is the tumor? I think that'll play a role in how I'd manage it. How would they tolerate a TME versus not. It's hard to, with those poorly differentiated features, that also gives me some really concern. That it just a transanal excision is going to be an appropriate modality. I'd probably lean towards more definitive surgery. I don't know that going forward with neoadjuvant therapy in this setting is probably necessary, but I'd probably lean more towards definitive resection. If it's something that we can preserve, GI continuity.
I think those are great points. And patient factors, tumor factors, and location all come into play. And just as a step back, as an aside for our residents, we do, MRI is one of the cores, has become the standard and the core of our, the foundation of our local staging for rectal cancer, which helps tell us, is it just in the rectum? Is it outside? Is it into the lymph node surrounding? And we've lost that clinical ability. So as a colorectal surgeon treating rectal cancer, I can tell you this is a very unsettling territory because you're sort of flying blind in the night. So in that regards, question for you: if you're going to do these advanced polypectomies in the rectum, ESD or advanced EMR, should people be getting a baseline MRI before, just in case it's a cancer, or are we going to be costing more healthcare dollars for that? How do you go ahead and decide that? How about Dr. Halabar? Are you there?
Yeah, it's a great question. I think that it depends on the local expertise, but I think it's pretty clear that ideally we would have that MRI before embarking on ESD to avoid the exact situation that's presented in this case. That being said, if the initial endoscopist is an advanced, colorectal surgeon, then they may opt to just do it at the same time. But I would definitely favor a staged approach to the ESD, attempt at ESD, just like we do a staged approach to many things in colorectal surgery, not just rectal cancer, but inflammatory bowel disease as well. And in this particular case, perhaps I logged on about 1 minute late. Perhaps just a 5C4 steps of the lesion as the initial first step might have been more appropriate.
Great, thanks for your comments. So, Dr. Halabar, what would your next step be then? Now you have this, lesion that's at least T1, T2, focally, positive at the deep margin. MRI is kind of equivocal. What are your next thoughts?
It's a great question. I think you have to have a thorough discussion with the patient about the various options, and importantly, get feedback in a multidisciplinary team, cancer conference, a tumor board. And clearly, the patient has an inadequate surgery at this point and needs to have additional therapy. And obviously, I think you need to decide whether or not this is a high risk for recurrence that needs total neoadjuvant approach before oncologic resection, or if you think that you can get adequate primary surgery without neoadjuvant, that would be ideal. The Pelican data and from Mercury studies suggest that upfront surgery for early T3s, T3A and T3B can have the equivalent long-term oncologic outcome with upfront surgery, avoiding the risks that are part of the neoadjuvant approach.
Great points and great, I think utilization of that study and interpreting that literature to help in this exact clinical scenario, I think is useful. Dr. Widmar, I'll get back to you to see where you went. I'll say as an aside, personally, I agree with the comments that have been made. I would be uncomfortable not doing anything, and I'd also be worried that another transanal excision of this ulcer, are we getting everything? Is there anything more? But a 51-year-old at 7 centimeters, I would also lean towards surgery as the next step. But Dr. Widmar, back to you.
Sure. So I'll share with you kind of the thought process that went through our DMT, because I think that's the most interesting part of this case, is that you actually do have several options. There are a lot of unknowns. So what can we look at in the literature to help guide us? It's a lot of data to go through, but let me see if I can, let's see, share. Oh, there we go. I'll kind of try to get through it, at least explain how we think about these cases when they come in. So there we go. This is the NCCN guidelines, what I put up just for the sake of putting it up. You know, I think we followed appropriately what was supposed to happen. This came to us. I had some unfavorable histologic features. We got some imaging. And then the NCCN presents us with two options, transanal versus transabdominal resection. But I think we all know that there are increasingly different options that we consider in a DMT setting. And it all has to do, as we talked about, with patient factors and the patient's desire to preserve the rectum and to guarantee, you know, sort of long-term good quality of life and bowel function. So let's go down the path of transanal excision. At a minimum, we said we're dealing with a T1 with high-risk features or a T2. We've known for a very long time that local excision alone for a T1 tumor with high-risk features or a T2 tumor is probably not good enough. This is data back from Dr. Yu's study, published in 2007, showing a difference in local recurrence rates in both T1s and T2s when comparing local excision to formal resection. In terms of disease-specific survival, this was actually an interesting study. She was able to show a difference in disease-specific survival in the T1 group, but not in the T2, but suggesting again that oncologic outcomes for local excision alone for these tumors is not good enough. This is a series of different studies that Dr. Nash looked at in 2012, just to kind of benchmark things for us. You know, with traditional local excision, we're expecting local recurrence rates as high as 28% in the T1 group, up to 45% in T2. Not very good disease-specific survival. With the advanced platforms, we get a little bit better, certainly in disease-specific survival, but with local recurrence, we're still dealing with high rates. And when we benchmark that to formal resection, we can see that there's a substantial difference. So I think all of us, and this was brought up in the discussion, would feel that local excision alone is probably not sufficient for this patient. So we know that if we go down the path of local excision, and this is essentially a biopsy to some degree, and we're going to need to follow it up with something. If we're following it up with TME, we've always been concerned about our ability to perform a sphincter-sparing procedure once we've done a local excision already. And we're certainly concerned about compromising the TME plan. I think this is especially true, obviously, anteriorly, where we don't have as much tissue to work with after local excision. The question is then, can we follow it up with chemoradiation? We've done a local excision just to kind of prove to ourselves that there's cancer there, or at least to prove to ourselves that there's nothing left there, and that all we're dealing with is a T1 with high-risk features. But then we need to give some sort of adjuvant therapy. This is the Cancer and Leukemia Group B study. This was published a long time ago now, 2008. The T1 tumors in this prospective study were not treated with chemoradiation in the adjuvant setting, but the T2 tumors were. And there are about 52 of them that underwent local excision followed by chemoradiation, looking at disease-free survival, overall survival, and disease-specific survival. And what you can see here, stratified by T-stage, is you're looking at a 64% disease-free survival in the T2 tumors, 66% overall survival with a local recurrence rate of up to 18% when we do local excision followed by chemoradiation. So clearly not ideal outcomes for these patients, even when we give chemoradiation in the adjuvant setting. For T1 tumors with high-risk features, really a single study addressing this issue. If you do a local, this is transanal, by the way, so local excision followed by adjuvant chemoradiation for T1 tumors with high-risk features. This is a study coming out of the Japanese University Hospital Network, phase 2 study, who then got chemoradiation in the adjuvant setting. And actually, they did okay. Disease-free survival, 94%, overall survival, 98%. This is the single study that exists addressing this point, but suggests that maybe for T1 tumors with high-risk features, we can compensate for the poor biology that we saw in local excision with some chemoradiation, even though that goes against, you know, a lot of what we know historically with rectal cancer. How about if we just go straight to TME, as was proposed by some of the people who were discussing? So again, if we're talking about an early stage tumor, really excellent outcomes, right, in terms of local recurrence, distant recurrence, and disease-specific survival. We know this from multiple studies over the years. This is probably in many ways the safest answer, and according to the NCCN is the preferred answer. The issue is that we lose something there, right? This is literature. This is from the Dutch TME trial, an analysis done years after the fact, looking at long-term quality of life and bowel function in these patients. We know that in patients who get radiation followed by TME, you have a major LARS rate. Sorry, this is a little fuzzy, but you have a major LARS rate of up to 60%, 55%. But you have a 36% chance of major low anterior resection syndrome in patients who underwent TME alone. So that's pretty substantial. It's not that if you undergo TME alone without radiation that you're kind of free and you're going to have excellent quality of life and bowel function in the long term. So it's an important thing to keep in mind. This is a tumor at 7 centimeters. So, you know, if we're going for a decent margin on this person, we're going to be doing a TME, right? This is not going to be a tumor-specific TME where we're leaving a good amount of rectum behind. You're going to be anastomosing this person just above the anorectal ring. Lots of randomized trials looking at morbidity, mortality after lower anterior resection, and long-term bowel dysfunction, urinary incontinence, and sexual dysfunction in both men and women. So TME is not free, though it may be, quote, the safest. How about if this is a T3 with a negative circumferential resection margin? That's how we want to approach it. We believe the MRI. We do think that this goes beyond the wall of the rectum, but we're pretty confident with our margins. While the NCCN would still recommend that we follow this up in the adjuvant setting with chemoradiation or radiation. At a minimum, they would recommend chemotherapy in the adjuvant setting. Notice that in the American guidelines, at least, you can only avoid radiation, or they only recommend that you avoid radiation if for proximal tumors, which this is not, or for tumors that are margin negative, maybe you can give just chemo alone. The idea of observation after formal resection for a T3N0 tumor in the American, in our national setting, is really only for T3A tumors. And this was staged as a T3B, though, of course, who knows if we can trust that. And we know from the German study that if we do proceed with TME and give this patient adjuvant chemoradiation, that we may have some problems, a significant increase in grade 3 adverse events, also long-term adverse events, and a substantial rate of anastomotic stricture. So this impacts our patient giving radiation after TME. As was mentioned, this maybe the tide is changing a bit. Increasingly, groups are looking at these favorable, these good actors, T3AB, in some cases, all stage 2 tumors. Can we proceed straight to TME without giving chemoradiation before or after? And it seems like we're getting pretty good local recurrence. This is definitely an option. And I think that this, makes a lot of sense, and it's certainly supported by multiple guidelines and supported by the data that exists, though, again, we're paying for it to some degree in terms of bowel function and quality of life. How about chemoradiation? So we've done an ESD. It's not a transanal excision, but it's an ESD. We're looking at a T1 tumor minimum with high-risk features, maybe T2, maybe even T3. What if we just give chemoradiation next? And this is, we have to kind of really draw from what exists in the literature, and it's not perfect, but these are 2 studies looking at T2 tumors at least, the Italian study and Dr. Garcia Aguilar's study, giving in this setting, it would be almost like a neoadjuvant setting because we've not formally resected this tumor in any way. We give chemoradiation, and then let's suppose we want to follow this up with local excision, whatever we see there. We can expect that we're going to have pretty good survival metrics if we do that. And this is, in fact, a T2 tumor or a T1 with high-risk features. But of course, the thing that we learned really from these studies was that, at least in Garcia Aguilar's, up to 44% of these patients are going to have a PCR. So if we're going to give them chemoradiation next, maybe we can just leave them alone and watch them, right? We don't need to follow it up with a local excision or anything else like that, understanding that we're going to be compromising bowel function if we do that. If 44% of these patients are actually going to be completely, to some degree, have a PCR, at least in the rectum, locally, have their rectal cancer fully managed by just giving chemoradiation. How about if this is a more advanced tumor? If we're looking at a T2 or a T3 tumor at 7 centimeters from the anal verge, we want to give chemoradiation and follow this up with something like local excision. We can kind of draw from the GREC-R2. So this was an interesting trial looking at lower rectal cancers that were T2, T3, and X. They get chemoradiation. They look at the response. Obviously here we can't look at the response. We don't have a tumor to look at, but we're left with the option of proceeding then with local excision or TME. Survival data, pretty good, but I think what the biggest learning point after the GREC-R was really in terms of morbidity. So if we give chemoradiation and we follow this up with a local excision, but that local excision still has T3 cancer in it or high-risk features, and we then have to go on to do a total mesorectal excision, look at our rates of morbidity here. So this is the group that got local excision plus completion, total mesorectal excision, completion surgery, 78% rate of major morbidity or side effects, 46% of high grade according to the Clavien-Dindo classification. So when we combine radiation with local excision followed by surgical resection, TME, we're giving people a lot of morbidity. So if we kind of commit ourselves to a chemoradiation path, we have to think critically about what our next step is going to be. Are we going to follow that with local excision? Are we going to give them a chance for just observation? Or are we just going to give them chemoradiation only to then go on to formal resection? And if that's the case, why don't we just operate on them off the bat? And I think that that's what we've learned in the past, I would say almost 20 years now, is that if we're going to give chemoradiation, probably the idea is to think about at least a trial of non-operative management. We're trying to preserve the rectum as much as we can, because the moment that we've given chemoradiation, we've sort of obligated the patient to a poorer, let's say, quality of life and bowel function, regardless of what the intervention is that follows it. Now, the issue in this case, as we brought up, is that the whole idea of non-operative management, and the reason why we feel comfortable with non-operative management in select patients, is that we learn something about the tumor biology when we radiate the tumor and then see its response, right? And in this case, we've kind of lost that ability. We cannot follow this tumor. We can't see how it responds to chemoradiation. We're giving chemoradiation to a scar. And so we lose that comfort level in saying, okay, we think this is probably a good actor from a biological sense that we can potentially offer non-operative management to. How about TNT? I mean, is there any data for TNT for if this is a T1 tumor with high-risk features or a T2 tumor? Are we just massively overtreating this patient with its associated morbidity? It's interesting that, unburdened by data in this setting, the NCCN, the most recent version published, suggests that in patients who have undergone a transanal local excision, and obviously we didn't do a transanal excision, but to some degree, we've taken out the tumor and now we're left with what we have. A T1 tumor with high-risk features, T2 tumor, we should follow with chemoradiation and consider adjuvant FOLFOX or CAPOX. So we're talking about giving TNT, adjuvant chemotherapy, for a T1 or a T2 tumor. And the data for this is essentially none, right? We have a hard time even proving the benefit of adjuvant chemotherapy for rectal cancer, period, right? That is, it's much less so for early stage rectal cancer. So why is this here? And this is here for one very specific reason, which is if we're looking at a T1 tumor with lymphovascular invasion, is lymphovascular invasion really a marker for local recurrence or for distant metastatic disease? And if we're going down the paradigm that this high-risk feature of lymphovascular invasion or poor differentiation is a marker of something that has a propensity to recur in the distant metastatic setting, then our biggest tool against distant metastatic disease is chemotherapy. It's not radiation. And we've known that for a long time. So, this is an interesting part of the NCCN guidelines where it's very difficult to point to the data that supports these recommendations. It really is sort of an abstract kind of thinking through the problem, thinking through the conundrum. So how about observation? There's a lot of studies looking at observation versus immediate salvage for tumors that have undergone local excision. Again, this isn't a formal local excision, but we have to draw from that data. And we know Weiser published a very good study that if we just leave these people alone, they're probably not going to do well. But what about if they're undergoing active surveillance? And I think Dr. Borsic published a really interesting study looking at groups that had high-risk features after local excision that were watched closely, that were sort of just left to follow up, or the patients that underwent immediate salvage. And what they showed is that we can probably, if we're watching people really, really closely and salvaging them only if they have evidence of recurrence, this was using endorectal ultrasound, endoscopy, and CEAQ 6 months, they probably do okay. So maybe we can just watch this person very closely. And if they're willing to come in every 3 months, maybe for a flexible sigmoidoscopy, maybe MRI every 6 months, kind of using the paradigm that we use for non-operative management, we will catch them if they recur and we'll be able to salvage them effectively. So I think, as many people pointed out, at least we're dealing with a T1 tumor with high-risk features. We have several options, and it's very difficult to draw on any data to really guide the best next step. We have to think about optimizing quality of life and optimizing oncologic outcomes. And I think the jury's out in terms of what the best next step is for this patient. I'll tell you that at our own tumor board, there was a very strong contingent pushing for chemotherapy alone. The idea being that if what we're worried about in this patient is not so much that there's residual cancer in the wall of the rectum, because we see a good scar, flexible sigmoidoscopy. We don't trust the MRI because we know that's propensity to overstage T as T3 based on a desmoplastic reaction, which this patient is going to have. The thing that we're kind of hanging our hat on in terms of further treatment is the high risk features of lymphovascular invasion. And what is that? What are we really worried about when we're talking about lymphovascular invasion? We're talking about distant metastatic disease. So maybe what we do is chemotherapy and just watch them. And the nice part about giving chemotherapy is that unlike chemoradiation, we're not obligating them to a path that is certainly going to compromise bowel function unless we're doing chemoradiation with unoperative management. So really, what's our next step? You know, I bring it back to here and I don't have an answer for you. I think everybody just gave some really interesting and good alternatives, but I guess I'd put it back to the group if in any way, shape, or form the presentation of this data has swayed you in one way or another.
Great presentation. Thanks for coming through with all that literature. And I think that's a great summary and shows how critically you guys were thinking about this very challenging case. I have some thoughts, but I'll give it to the group first. So Dr. Trunzo, let's go back to you. Now, after all that presentation, that data, would you opt for chemotherapy alone? Are you thinking radiation? You still sticking straight to surgery? What are your thoughts?
Yeah, I think, you know, the interesting point that you can see is there's no freebies no matter which path you take. You know, there's a divergence of, you know, quality of life if they don't have a good disease-free survival versus the functionality of their GI tract after they have a proctectomy. So, you know, it really is, it does come back to the patient a little bit too. You have to give them at least some discussion about but you know, the problem we have with some of these patients is many of them turn it around on us and say, what do you recommend? And they have a hard time making that decision, you know, and I think we have to, you know, again, in a young person that's 50 years old, like this patient, you know, I guess I'd probably still lean towards definitive surgery. I think I'd rather deal with, from a, you know, personal standpoint, I've seen some of these recurrent ones. They're not so easy to salvage at all times. And I think, you know, you have an opportunity to do a curative operation on a young person that has a long life. Yes, you'll be dealing with potential functional things, and sexual dysfunction is real, especially in young male and all these things. But I guess, you know, taking that into consideration, if he turned it around on me, the patient himself, and said, what would you recommend? I'd probably lean towards definitive surgery because I think in a younger person, that's probably going to be his best long-term situation. But again, I think you can't, I think you can have someone argue every single one of those points. I think that was a very well described depiction with supporting literature and all those different scenarios. I think that was very well done. So I commend you.
Dr. Liska, I think you are now, I know cell phone service is spotty driving in your Maserati. So if you're able to unmute now. And so what are your thoughts here? So, you know, we've had so the case was ESD, 7-centimeter anterior tumor, focally positive at the deep margin. You kind of heard Dr. Widmar go through the various options. Would you lean towards observation, towards just chemoradiation, surgery? What are your thoughts here?
Yeah, no, thanks. This is, you know, thanks, Dr. Widmar, for a really thorough going through of the data on this very difficult problem. One thing from the get-go that I would want to do is, besides looking at the scar after the ESD, is I would like to see the post-resection pictures during the initial ESD. And I know that when my partner, Dr. Gorgon, does ESDs, he during the ESD will get a very good idea if he's actually going through tumor, which you'd expect with a T3, or if it's really just a T1 and maybe just a focally positive margin. So I think that would, you know, depending on who the endoscopist was, and you can talk to that endoscopist and see what their impression was during the procedure, but also looking at the actual pictures of the post-ESD resection bed, you know, not a week or two after when this patient presented, but actually immediately during the procedure, what it looked like. I think you can get a pretty good idea of what type of depth of invasion this was, and that will give you a little bit of a better idea if the MRI is just overcalling it because of post-treatment effect, or if this really is a T3 to begin with, or at least a T2, because you can get that. You should be able, experienced advanced endoscopists can tell that during the procedure. So I think that's one thing I would lean on a little bit to help me with this decision. And then in terms of what you choose, do you choose surgery straight? I think that was definitely, from an oncologic standpoint, would make a lot of sense, especially in a 51-year-old. Obviously, we're dealing with all the Lars issues following a resection, maybe a little less risky without chemoradiation, and I think that would be still a very good option. Now, the TNT option, I think the reason why it's attractive here is because we've seen so many patients who've been able to avoid surgery with TNT. So I think it wouldn't be so much for the oncologic benefit, because I think oncologically we'd be very good with just going straight to surgery. But the TNT approach would be attractive in the sense of being able to go to a non-operative organ preservation approach. And I think that sort of comes down then to the discussion with the patient, where you talk about sort of probably both approaches, very good oncologic outcomes, and with the TNT approach, maybe being over treatment, but potentially giving you the option of watching weight with, again, not 100% obviously, but with if this really is, which we're thinking is an early lesion, a T1, T2 lesion, without any lymph node, I think the chance for a complete clinical response is very good. So I think that would be an option. And I know Dr. Tranza said that, ultimately our patients asking us what do we think they should do, and what that recommendation comes down to. And I think Dr. Tranza has been spoiled practicing here in Cleveland, where patients do listen to us. Having trained in New York, I know a lot of times patients come with their own agenda. But I think those are the two options to me that would make the most sense.
So you're saying either, give me your two options that you're voting for after all that. You said TNT and observation versus
surgery, TME
versus straight up surgery.
Yeah. I don't think the local excision or the chemotherapy makes sense here, because we have two issues. One is there's a positive margin, so we have an issue with tumor potentially still being there. And the second thing is we have the high risk features, so they're potentially being lymph nodes. So there's two issues. It's not just the lymph nodes, and it's not just the local problems.
Yeah, that's exactly what I was just going to say, Dr. Liska. With that positive deep margin, I worry about your FlexSig being useful to monitor this, because what if there's something deep that gets scarred over and then it starts spreading there? So that's one thing I would worry about, not about just observation. And yeah, exactly. The high risk features, we know T1s with high risk features kind of behave like T2s. So you're looking at least 15, 20% maybe chance of lymph node, positive mesorectal lymph nodes. But just chemo, not treating that, I guess then it goes to say, well, is your chemoradiation treating your lymph nodes, or is it just treating the tumor locally? It's sort of, what do you think about how that biology plays out?
And I would just kind of chime in that, the prospect data, we had 20% path complete response rates to chemo alone.
Right.
Positive tumor. So does chemo treat the nodes? Does
Right.
chemo treat the primary tumor?
Yeah, I think it's such a exciting but also difficult time to be treating rectal cancer, as the landscape is changing daily. And I think Dr. Trunzo and Dr. Widmar made great points saying that there is nothing free, right? Radiation has side effects too. The surgery has big potential chance of having issues with Lars, like you mentioned. So it's I think a lot of it, personally, I would probably opt for surgery, but also my personality is I don't like the unknown, sitting and waiting. Is there something growing? You don't know a definitive pathologic stage without a transabdominal resection. And that's kind of the thing I would always come back to. And then, you'd feel kind of bad if it comes back negative, but then you did the surgeon subject them, but then you'd have a definitive. So as I think a lot of patients tend to have that more mindset. I think that's probably the most common mindset. That's kind of where I would lean, but those are my thoughts. With that, and we're just about at the end. So Dr. Widmar, I'll give it back to you for any last thoughts, what your plan would be, what you're thinking.
So the attending whose case this was opted for, and the tumor board supported chemoradiation, no chemotherapy, and watched. And then the patient had an excellent response in the sense that the follow-up MRI 6 weeks after radiation showed essentially no tumor at all. And then it came back to the tumor board for consideration of TNT, right? Continue with chemotherapy for exactly what Dr. Liska mentioned, which is if our goal is non-operative management. Now, after 2020, we have several studies showing that when we give total neoadjuvant therapy, we'll probably increase the rate of that. And so the patient ended up getting TNT and has preserved the rectum in his NED.
So it did go through with consolidation chemotherapy.
We did, and I mean, I think that's our bias, right? As you mentioned, patients come to us because they know that we are a center that offers non-operative management and considers non-operative management in a lot of settings for rectal cancer. So the patient also is coming here with the desire for organ preservation. And if that is the goal, we've felt for some time, and again, like we mentioned with the studies published in 2020, we now kind of know that the TNT path is probably our best chance at non-operative management. So we take the risk. We took the risk in this case, even though the primary attending was a little bit against it, but we took the risk in this case of over-treating what is a T1 in terms of giving systemic chemotherapy, right? For the goal of non-operative management.
Excellent. Well, phenomenal presentation. For our trainees and for people out there listening, I would like to say, these are very difficult, challenging cases that, are treated, I think, in advanced centers that are doing some of these studies and doing these high-level things. It's very challenging. There's no defined level of standard of care. Before we break, there are two comments in the chat. I don't know who's saying them because there's no name to it. I think there's the point which we talked about earlier with consideration of MRI if you're worried on digital exam, which I think is a good point. And also to say, remember, you do not take the risk the patient does. I think that's true, and I think that's why it's important, just to have these conversations with the patient and try to express to them all, to the best of our ability, all the risks and benefits of each option and try to let them make as much of an informed response as possible. With that, I'd like to thank Dr. Widmar for an excellent presentation. That was a great summary of the data and of a challenging case, and very happy with the successful outcome, and hopefully it continues to be that way during the surveillance phase. As a reminder, let me pull up my little thing here. We'll be back next week with Surgery Live. We're every Friday except the first Friday of the month. Next week, Dr. Anthony DeRoss will be moderating, Dr. Jason Robertson talking about esophageal atresia and tracheoesophageal fistula, so a nice pediatric case. And thanks again to Medtronic for hosting. We'll see you next week on Surgery Live. Thanks for a great discussion.
Thank you.